Hello, everyone. This is the 27th episode of our famous fetal series on the Congenital Heart Academy. And it's a great pleasure to have all the support from the whole world that I've seen when I attended the World Congress. I just want to say thank you. And all the staff on board the Congenital Heart Academy are so grateful to your kind support. Today is a very special webinar. We have pillars in the world of cardiology and perinatal cardiology. Like to invite very famous Dr. to give the first talk. But before that, I'd like Dr. Devore to take us give us few lines about himself, about his journey, and so on. Most welcome, Dr. Devore.
Jim, you want to turn off your audio?
I need to sign anything?
I will.
Okay, turn off your audio.
Hang on.
Okay, it's a pleasure to be here. My journey began in 1979 at Yale University when I was the first maternal fetal medicine specialist in North America to begin to examine the fetal heart. Since that time, I've published well over 100 articles on the fetal heart, where I've been first author on most of them. We've generated a number of different programs. One, the most recent, is a program in evaluation of fetal cardiac size, shape, and function. It was incorporated into the GE system and it's known as Fetal HQ. So I've been involved with lots of development over the years and involved in teaching and promoting fetal cardiology. Today, my talk, though, is a little bit different. It's entitled A New Technique to Evaluate Maternal Cardiac Function in Patients at Risk for Fetal Growth Restriction. Now, this is a deviation. My experience has always been with the fetal heart, but I became interested in the maternal cardiovascular system several years ago. So this talk for the next 25 minutes or so will show you a technique that is very easy to use and that can be applied by most all physicians or sonographers. They only need a cardiac probe used in echocardiography. So let's begin. Background. It's very interesting to note that maternal cardiac death in the United States is 16.7 per 100,000 in 2016. It has increased from 1987, where it was 7.2 per 100,000. To provide perspective, car accidents in California, which is a crazy place, is 9.7 per 100,000. And women dying from drug overdose from synthetic opioids is 11 per 100,000. So you can see that maternal death is an important factor as far as the rate of deaths that occur during pregnancy. If we look at the risk factors by ethnicity, the Black population has the highest risk factor compared to the others. If we look at the reasons for maternal death, heart disease and high blood pressure account for over 41%. So it's important to be able to consider how we might evaluate the maternal heart other than simply the blood pressure. Now, these are the diseases that affect the mother: chronic hypertension, gestational hypertension, mild preeclampsia, and severe preeclampsia. All of these diseases can have a significant impact on fetal growth. And so it's important, as we look at fetuses with growth restriction, we may find many times the mothers have these different types of problems with their blood pressure. And the question is, how do we assess the mom who is hypertensive as it relates to fetuses that have a risk for growing poorly with growth restriction? So if we look at the cardiovascular system today, the only thing that is really done around the world is we measure the heart rate of the mother and her blood pressure. And the real question is, what would be useful information regarding maternal cardiac function other than blood pressure and heart rate? So that's the question that I posed as I started this study. The two things that are relevant, that are easily understood, because all of us have been through our physiology and our cardiology courses in our training in medical school, or even in our residency or post-residency. The two items I want to focus on today are cardiac output and systemic vascular resistance. Now, this is interesting. This is a diagram showing the preconception state for systemic vascular resistance, mean arterial pressure, and cardiac output. During pregnancy, at the 14th week, you can see there's a marked increase in normal women in cardiac output, a decrease in mean arterial pressure, and a decrease in systemic vascular resistance. And this pretty much continues on through labor and following delivery. So maternal state, pregnancy state, I should say, has a dramatic impact on the cardiovascular system of the mother as she tries to compensate for the pregnancy state. Now, this is, excuse me, an important concept that many people do not appreciate. If we look at blood pressure, and we look at cardiac output, and we look at systemic vascular resistance. Let me close this down a bit here. Systemic vascular resistance, blood pressure can be normal, the cardiac output can be normal, and the resistance can be normal. However, there are other situations in which the blood pressure is normal, but look what happens to the cardiac output. There's two profiles. Either it's decreased or increased, or the resistance is increased or decreased, and you see they're opposite of each other. The cardiac output is increased, the resistance is usually decreased. And so these findings I call things under the covers, so to speak. So you take a patient's blood pressure, it's normal, but if you do a cardiac assessment, which we'll talk about in a few minutes, you may find this occurring even though the blood pressure is okay. Now, pardon me, if we look at gestational hypertension, mild preeclampsia and severe preeclampsia, we observe that the blood pressure is increased, and there's different degrees. There's gestational hypertension, there's mild preeclampsia, and of course, severe preeclampsia, blood pressure is increased dramatically. And again, look at the various combinations of cardiac output and systemic vascular resistance that have been reported in the literature. In this paper published in 2019, it's called The Methods and Considerations Concerning Cardiac Output Measurement in Pregnant Women, Recommendations of the International Working Group on Maternal Hemodynamics. And what they showed was the various methods for measuring cardiac output. There's invasive methods, which of course we're not going to use, minimally invasive methods, non-invasive methods, and other technologies. This one focuses on echocardiography and the use of ultrasound, both pulse wave and continuous wave. So we're going to look at an ultrasound approach to examine maternal cardiac function. In the adult, the echocardiography done by a cardiologist uses two techniques to measure cardiac output and stroke volume. The first is measurement of the diameter of the ascending aorta as it exits the left ventricle, followed by measurement of the velocity time integral of the Doppler waveform. Using these formulas, one can compute stroke volume and cardiac output in liters per minute. This is from the same patient. Here, another approach is to measure the area of the ventricle and systole and diastole, and using Simpson's rule, they divide it into segments, compute the volume, and again, compute the stroke volume and cardiac output. You'll see both methods, the same patient, are very similar as far as their reproducibility and the findings. The problem with doing an echocardiogram in an obstetrical patient is it requires special training, takes 20 to 45 minutes, requires at least 2 cardiac images, and may be difficult in pregnant women, and probably impractical for screening. So while this is a gold standard, again, to use this to screen patients, it's a little bit impractical because you're not going to find a cardiologist necessarily in the maternal fetal medicine unit to do echocardiography, or a sonographer. So the question is, what other option could be available? Well, we're going to focus on the suprasternal notch. The study that we did, we obtained clinical information, maternal weight, height, and her blood pressure. And also we did the following measurements. We measured the aortic diameter, velocity time integral, heart rate, ejection time, and mean pressure gradient. These all come from the output of the ultrasound machine on the GE system. And here is the aortic arch that we measured, or that we identified. And from the aortic arch, that is imaged in the suprasternal notch, we imaged the diameter of the aorta, distal of the subclavian. And from these measurements, we're able to take and compute a number of different measurements. This is a paper published in the August issue of the American Journal of Obstetrics and Gynecology. It's entitled Assessing Maternal Cardiac Function by Obstetricians, Technique and Reference Ranges. This paper is open access. We paid dearly for that, but I felt it was important that people who maybe don't subscribe to this journal have access to the paper. And so this is published as a free download. There's also 2 videos in the supplement section of the article. So I would advise, if you're interested in this topic, to go to this paper and download it and read it. So here's what the study consisted of. We examined the descending aorta. And the reason for that was because in the aortic arch, the ascending aorta was more difficult to image. We only saw that about 5 to 10% of the time. However, we can image the descending aorta in over 98% of patients. We had 400 normal patients between 11 and 38 weeks of gestation. We used fractional polynomial regression analysis that consists of 44 equations to identify the equation that best predicted the reference intervals. We then computed z-scores from the mean and standard deviation and the measurements we made. And this is how this was reported. This is a video showing the technique. I'll click on it. First of all, we raised the patient off the table, placed the pillow behind her shoulder. Her head drops to the back and turns to the left. We placed the probe in the suprasternal notch. You can see it's at an angle of about 45 degrees. So we just place it there. And then the next sequence, you're going to see that after we place it, we rock it towards the maternal head just a bit to open up the aortic arch. And you'll see that in just a second. Now we're going to measure the descending aortic diameter at the junction. So there's the aortic arch. And you'll see in a moment as we place the cursors on the screen to make our measurement. There we go. And next, we're going to activate the color Doppler and place a sample volume in the center of the descending aorta. This is using pulse Doppler, and you can see the color flow. There's the waveform. Now we're going to measure the velocity, time interval, heart rate, and ejection time from the pulse wave. So simply we trace the outer contour of the waveform. And that computes. Now we're going to measure the heart rate. And finally, the velocity time interval. And these measurements are the ones that we use in our calculation. We enter the clinical information, and here we have the clinical information. Here the weight of the mother, her blood pressure, and the measurements from the exam I just did. Then we can compute the preload, afterload, contractility, and cardiac flow. And for our purposes, for this discussion, we'll discuss cardiac output and systemic vascular resistance. Okay, let's now see what we found. These diagrams are from our 400 patients: systolic blood pressure, diastolic, mean arterial pressure. You'll see in the first trimester, there's a drop in systolic and diastolic and mean arterial pressure up through about the 17th week. And then the pressures slowly rise till the end of the pregnancy. If we look at maternal heart rate, there's a decrease in heart rate, and then that also increases over time. This is the continuous wave and pulse Doppler velocity time intervals. You see they increase to about the 18th week, and then they level off, and then they decrease from 24 weeks to term. And this is also represented by the stroke volume. Again, an increase in stroke volume to about 20 weeks, it levels off to about 28 and then decreases. The same thing with cardiac output. I'm sorry, let's do this right here. Cardiac output. So again, increase in cardiac output, taper, it levels off and then decreases. So this is the profile of the pregnant woman from 10 to 40 weeks of gestation. And this is a systemic vascular resistance. You see it decreases, and after about 32 weeks begins to increase. Okay, now this is the report that we generate, and this calculator is available on the website. When you download the paper, you can obtain this calculator and simply fill in the information in the yellow boxes or yellow cells, and then it does the calculations, gives you the corresponding z-score of the measurement and its equivalent centile. This is what I look at. I look at the centiles because that's easy to understand. Okay, let's look at some clinical studies that validate this. Now, this is using a technique similar to what I did. It was a US comm device, a continuous wave. It was placed in the suprasternal notch. However, it was blinded. They did not measure the aortic ascending aorta, or could they determine by visualization where the place the pulse stopped? So it's done blinded. But these are the first studies that use that device in pregnant women. If we look here, for example, screening for preeclampsia in the first trimester, the role of maternal hemodynamics and bioimpedance in non-obese patients, you see that in the controls, the preeclamptic group, the systolic blood pressure was not different. However, the diastolic pressure was higher and the mean arterial pressure was higher. The systemic vascular resistance was increased in preeclamptic patients, and the cardiac output was decreased. Growth restriction, which is one of the groups that we're interested in. This is a very important concept. There are three different types of growth disturbances that are defined in the literature. One is early fetal growth restriction occurring before 32 weeks, late growth restriction between 32 to 40 weeks of gestation, and fetuses who are small for gestational age. As these patients are profiled, we see that the systemic vascular resistance is highest in the early growth restricted fetuses and then decreases as we approach small for gestational age. And the cardiac output is low in the early FGRs, but increases as the fetus develops either late FGR or SGA. So this concept of decreasing systemic vascular resistance with less severe disease, or the other way around, the more severe the disease, the higher the systemic vascular resistance and the lower the cardiac output. There are other studies that have looked at predicting adverse labor. This study here was done, and they looked at 133 women were included in the study, 34 who had adverse outcomes. And this just illustrates the systemic vascular resistance adverse outcome. The resistance was lower, and here we have the same thing here. Okay, maternal hemodynamics, early in labor, possible link with obstetrical risk. This study just basically showed as the labor complications increased, the systemic vascular resistance increased. So there's a correlation. The higher the resistance, the worse the outcome as far as neonatal problems are concerned. Now, what I'm going to show you now, and this is probably the value of what I did, is how to adjust the medication in hypertensive patients or patients at risk. Now, as I said before, hypertension is a precursor for growth restriction. So what we're going to now talk about or illustrate is examples of patients in whom we did the analysis, and you'll see how we altered or suggested changes in the care of the patient. And the whole purpose, of course, is to try and prevent the hypertension and its associated problems with fetal growth. So let's begin here. Case 1. High blood pressure adequately treated with medication. The patient was hypertensive on labetalol, 400 milligrams a day. So if we look at the top graphs, and these will be the same as we go across, mean arterial pressure, systolic pressure, diastolic pressure were all normal. Systemic vascular resistance, stroke volume, and cardiac output were normal. So in this case, when we evaluated the patient, I informed the obstetrician the drug of choice, labetalol, was appropriate, and the dosage was appropriate because the cardiovascular profile was normal and her blood pressure was normal. In this case, the patient was 22 weeks, had chronic hypertension, treated with labetalol. Her blood pressure was normal, but if you look at the profile, her resistance is down and her cardiac output was increased. So in speaking with a clinician, I stated that while her treatment is appropriate at this present time, if her blood pressure increases, the drug of choice would be to increase her labetalol. In this case, the patient was 18 weeks. Her blood pressure was 140/90. her systemic vascular resistance was increased and her cardiac output was decreased. And so the drug of choice when she was being treated was nifedipine because it's a calcium channel blocker and decreases the resistance. And what happened when she was begun on nifedipine, 4 weeks later, her blood pressure is normal, her systemic vascular resistance is normal, and her cardiac output is normal. So again, we use the information from this assessment to tailor make what drug of choice would be appropriate for her to be treated with her hypertensive disease. Here's a patient at 18 weeks, 173 over 110. This was newly diagnosed. So we look at the profile. The resistance is normal, but the cardiac output is increased. We recommended they start labetalol to decrease her cardiac output and control her hypertension. Another example, chronic hypertension treated with nifedipine. We have an increased resistance, decreased cardiac output. And again, what we recommended was when the blood pressure increases, the physician should increase the nifedipine because that's the drug of choice given the profile that we see right here. Another example, 15 weeks treated with nifedipine, her diastolic was increased, her output was increased, her resistance was down, she was on the wrong drug. So I suggested to the clinician, stop the nifedipine, begin the labetalol, and this is 4 weeks later, normal, almost normal blood pressures, and you see her cardiac function, her cardiac output is normal, her resistance is normal. So again, we altered the hemodynamics by selecting the correct drug given what we saw with our prior study. 30 weeks and 3 days pregnant patient treated with hydralazine. Again, hypertensive. You see the profile, low systemic vascular resistance, increased cardiac output. We suggested they stop the hydralazine, begin labetalol, and this is what we saw 2 weeks later, normal blood pressure. Again, the profile shows still an increase in cardiac output. And so if the hypertension increased or the diastolic increased higher or the systolic pressure increased, physician could add more labetalol because this is the underlying cardiac profile. Okay, clinical studies risk for preeclampsia. This patient is 33 weeks. She has notching of the uterine artery, normal blood pressure. This is her cardiac output. This is her systemic vascular resistance. And this is the study that illustrated these relationships. And so in talking with the referring physician, I suggested if she demonstrates evidence of increased blood pressure, she does have a risk for preeclampsia, that the drug of choice would be to consider nifedipine because of the high resistance and low cardiac output. So, and again, these are clinical studies I referred to previously. Again, here's a case, previous pregnancy with IUGR, 23 weeks. The profile shows a high resistance, low cardiac output. This is the profile that one would expect if the pregnancy develops preeclampsia or severe IUGR as time progresses. So we basically, when I see this, even though the blood pressure may be normal, I counsel the referring physician that she has a risk based upon this profile. So in conclusion, what I've shared with you in brief 20 minutes is a new technology. Actually, it's an old technology, but using a cardiac probe, and almost all the machines that are available for fetal use have the ability to accept the cardiac probe, and the cost of the probes are relatively inexpensive and can be used. And most machines have, when you make the measurement of the velocity time interval, gives you the data you need to put into the calculator that I showed you to do the computations for cardiac output and systemic vascular resistance. I think that this has a real potential to change how we care for our patients with hypertension or those at risk for preeclampsia or who have growth restriction, because you can now understand the underlying cardiac profile of the mother other than simply measuring her blood pressure. And if you think about this, if we look worldwide, the maternal death rate, and much of it is because of uncontrolled hypertension or poorly treated hypertension, this, I think, is a great opportunity to look under the covers, understand what's going on hemodynamically, then treat the patient accordingly. Thank you.
Thank you so much. Very, very interesting talk, Professor DeVore, yet not easy to grasp. Dr. Huta, do you have any questions?
I just think it's a landmark video here, but Greg, I want to share it with all referring doctors that I deal with. But most importantly, I want to share it with the perinatal cardiologist. You see, when I talk to them about IUGR, they say, "Oh, well, what the heck difference does it make? What can we do to make a change? What can we do to help the situation?" I say, "Well, they could stop smoking, maybe." Let me ask you quickly, Greg. What's the place of aspirin therapy? Many of our patients come to us on low dose aspirin therapy.
Well, there are several approaches to looking at the risk in the first trimester, and basically there's some biochemical markers, but are not really available in the U.S. I use the uterine artery Doppler, of course, and I make it simple. Some people, and there are nomograms to look at the PI of both uterine arteries and add them together and divide by 2 and come up with a risk factor for preeclampsia. I use a simple technique called uterine artery notching. And notching is an indicator of a higher resistance to blood flow to the placenta in the first trimester. So I use that as my diagnostic tool. Then I place the patients on 2 baby aspirins, 162 milligrams. And then when they come back in the second trimester, I repeat the exam. And currently I'm also doing the maternal cardiac profile that I just talked about. And if the notching is resolved, then I stop the aspirin. If it continues, then I continue it. And then I evaluate the fetal growth at intervals in the second and third trimester.
Very nice. Yeah, I think.
Why 2 aspirins? Why 2 aspirins, Dr. DeVore? Why not 1?
Well, the earlier studies suggested that 81 milligrams was the first choice. And then subsequent studies out of Europe showed that 150 was a better choice. And since we don't have 75 milligram tablets in the US, I use 2 of them for 81, so I get 162. So there's not a lot of difference between 150 and 162. The 2 doses or the higher dose of aspirin has been shown to be more efficacious.
Greg, thank you for that. The European studies really guided the way at the original 18-week studies. As I understand it, let's make sure that I have this correct. You identify the subgroup in which IUGR may occur. A notch at 18 weeks doesn't mean that they're all going to get IUGR, but you have now identified a subgroup to look at further.
That's correct. And the subgroup that identify, I then start them on the low dose aspirin, and many times it resolves. But at least I have a head start if it doesn't. Because it's been shown if you start the aspirin later in the second trimester, it's not as efficacious in preventing the severe IUGR and preeclampsia.
Pardon my ignorance. I mean, we are trying in this scenario. We're just talking about IGR secondary to preeclampsia.
Well, okay. IUGR or fetal growth restriction has many etiologies. Patients with preeclampsia, and if we look at severe preeclampsia, often the fetus stops growing before the mother manifests the severe preeclampsia symptoms, sometimes several weeks beforehand. So if you have a patient that has growth restriction, for example, and you look and the mother's blood pressure is not elevated, and you look at the cardiovascular profile I just showed you, and the resistance, systemic vascular resistance is high, and the blood and the cardiac output is low, bingo, you have an under the covers strong indicator that this mom is going to develop the preeclampsia. And if you have a patient, for example, in labor, and you're wondering, do I have gestational hypertension or do I have preeclampsia? You do a maternal cardiac profile. The gestational hypertensives have a high output, low resistance, and the preeclamptic patients have a high resistance and a low cardiac output. So you can use that tool I just described in this lecture to help guide you to understand what you may be facing clinically.
Are you trying to say, okay, if you find a growth restriction and the blood pressure is normal, just go dig and find perhaps he is going to develop a preeclampsia. Dr. Nicolaides is also in this forum before, and he told us that he's working on a preeclampsia sort of panel. He's doing like blood tests for that.
Well, let me tell you what he did. In the American Journal of OB/GYN, he has a paper that's in press, And he has, if you go to the website, Fetal Medicine Foundation, they have a preeclampsia calculator, okay? And the calculator has historical information about the mom or past history or medical risk, et cetera. And then you put in the uterine artery Doppler PI, and you have the choice of adding two results from two biochemical markers. Unfortunately, those are not available in many places. He just published a paper in which he measured what's called the pulse wave velocity. And it's using a device that I just acquired it a few weeks ago. And you basically take a measurement from the brachial arm, the upper arm and the ankle, or the neck and the upper leg, and it measures the velocity time between those 2 points. And you plug that value into the calculator, which will be available in December. And it's been shown that that measurement replaces the biochemistry, or performs better than the biochemistry. And so it'll be something that can be used very easily and clinically throughout the world. So that will be coming. The paper's in press, or you can look at it. And the device is called the Vicorder, Vicorder. And that device allows the clinician to make that measurement within about 2 minutes.
That's very, very interesting. Do you mind going back to the meat of the talk here, where you did the measurements and then you put them on the screen, and that was very quick. Doing the descending aorta flow and putting in the data. So and then the outcome comes. So I mean, just to make it easy, so you go to the suprasternal notch and go to the left and do the descending aorta, and you do the measurements distal to the left subclavian artery, and you measure the VTI, and then you get all this coming, or you have to set the machine, the GE or whatever, you have to give you the PI. I don't know. I can't really see a lot here. Maybe you can make it a little bigger.
Let me explain it. Here's what it does. This is the GE expert, BT 22, BT 21. It has it on all the machines. You place the pulse Doppler here. It then gives you these measurements. I've highlighted velocity time interval there, pressure gradient, ejection time, and heart rate. That's all that you need. So you plug those to this calculator: aortic diameter, heart rate, mean pressure gradient, ejection time, velocity time interval. Of course, you have to fill in the maternal characteristics. What's her height, what's her weight, what's her blood pressure, and the gestational age, okay? Then automatically it makes these computations here: weight in kilograms, height in centimeters, body surface area, mean arterial pressure, velocity time interval in centimeters, gestational age. And then it gives you the corresponding z-scores and the percentiles. And then I divided it into concepts: the preload. How hard is the heart working against a preload? Well, these are some measurements: stroke volume index, stroke work. And these are the percentiles for that measurement. They're normal. Afterload, these are some sophisticated concepts that I won't go into, but we have systemic vascular resistance. You see that it's normal. Contractility, inotropy. This, again, sophisticated measurements, looking at how well the heart squeezes. And then finally, cardiac output. So I've chosen cardiac output and systemic vascular resistance as two of many of the things we compute, because they're conceptually easy for people to understand.
And then this will plot it on a graph, and it gives you the centile?
Well, it has it right now in this format, and these are the percentiles. For my clinical use, I then develop the graphs that I showed you.
Okay.
If somebody's interested, I can certainly send them the calculator that is the second version of the calculator, that you enter this information, and then you click a tab, and it gives you then the graphs that I showed you.
Greg, it sounds to me like you're talking about a maternal cardiovascular profile, and it really is it's a 2x3 table.
Yeah, it's a maternal cardiovascular profile. This is what it is. And I've shown, this is the case that I reviewed very quickly, the practicality of its use. I mean,
just in the case of preeclampsia, this profile, just for that, or for anything else?
No. Ideally, you know how long it takes to do this examination?
It's probably 3 minutes in a cardiologist hand and 5 minutes in an OB hand.
2 minutes in a maternal fetal medicine hand. No,
Okay.
it
No.
takes just a few minutes. And we
Okay.
have the calculator open on the screen because we have a computer in the room, of course. We open it up, put in the stuff after it's measured, or read it off. It was done in 3 minutes. And you can have a whole profile of a patient. And when you examine a patient, say you'd screened everybody this way, it took 3 minutes to do this, you'd have a clear understanding of a patient in the first trimester who may develop hypertension or who may develop preeclampsia, or you have the hypertensive patient that comes in, you take her blood pressure, it's up, and you ask, what's your profile? What medication are you taking? You need to increase the medication. Are you on the wrong medication? I mean, it's so useful.
It's beautiful. Yeah.
It's
Yeah.
very very
Yeah.
simple, and it all the diseases. You're getting the mother's hemodynamics, and that falls into those three classes, or rather two classes, really, and times three. So it's a 3x2 little box, okay, that you can check, or you can check. His algorithm will give you the answer too.
Yeah.
But
And
also it'd be good to hook the cardiovascular fetal profile score to the maternal profile score and see if they agree.
No,
well,
they wouldn't. They wouldn't
yeah,
necessarily agree, but they would help. Both of them would help you in managing the pregnancy.
yeah. And again, I use this every day, and I can tell you it's changed my practice. I am not driving blindly when I have a mom with hypertension, and I'm uncovering changes in mom's cardiovascular system that will predict what may happen in the future.
But
Nice.
Dr. DeVore, you wanted to use two medications for hypertension, and these are not combination medications. Most people, I'm not sure in pregnancy, but nowadays in hypertension is treated by combination of drugs. You've used
Yeah,
one drug and in one calcium channel blocker and the other one beta blocker or whatever.
yeah, yeah.
Do internists agree to that?
Well, here's what's interesting. If you look at what's recommended for pregnant ladies,
Mm-hmm.
labetalol, nifedipine, and Aldomet are the drugs that people have used. Aldomet for years, more
Yeah.
recently labetalol and nifedipine. Okay,
Mm-hmm.
and they use nifedipine as also for premature labor. So there's two drugs familiar to obstetricians. And again, if you look at the simplicity of what is your cardiac profile, one drug decreases your cardiac output and the other one decreases your resistance. And so you tailor make it. And I've not had any patients yet that we had to say to a cardiologist or an internist, gee, these drugs aren't working. What do you suggest? Because we understand what's under the covers. And that's what makes it so nice.
Brilliant, Greg.
So that's
It's beautiful. It's really, Dr. DeVore, you're also the one that spoke about the abnormal flow and the descending aorta in IUGR, right?
yeah.
So what was that? And then I mean, you're always after the descending aorta. I wonder why.
Well, no, it's just the descending aorta in the mother I'm talking about now. Not
Yeah, but
and
also, I mean, you like the descending aorta, whether it's a fetus or the mother.
well, the fetus, I don't like the descending aorta. I like the isthmus. Okay,
Okay.
I'll tell you why real quickly. And I know you got to go. If you look at the aortic isthmus in the fetus, if you have bidirectional flow at that level, you have a mismatch of cardiac output of the right and left ventricle.
I'll
Because
show that, Greg.
Jim's going to show that. That's a very easy, quick way to understand what's happening hemodynamically and ventricular output in the fetus with various problems. So I'll let Jim go into that area, but that's the area that I go after when I'm also looking at mismatch.
Without any structural heart disease, just looking at the isthmus with IGR?
Yeah, most of the cases I deal with are not malformations. I mean, they're 3 per 100,000, 3 per 1,000. I'd be, the cases I see all the time are a lot of growth restriction. And there's the fetal echo functionally that Jim will talk about in his talk. And what I've done in my publications, the growth restricted or the fetus at risk for growth restriction is the huge group of patients that these tools apply to directly in their management, their care, and their understanding what's going on. I mean, we can predict who's going to get into trouble in labor with fetal distress.
Beautiful. Thank you. One
Oh,
question for you before you leave. I know you have to start your clinic. Preeclampsia with gestational diabetes, what are your recommendations to manage from Orlando? Yeah,
you mean if a
so
patient has preeclampsia and diabetes?
yeah, gestational. How are you going
Well,
to manage?
I would take them at least to 36 weeks if the preeclampsia is mild. If they have severe preeclampsia, they get delivered irrespective of the diabetes situation. And they, of course, would give the mother steroids for fetal lung maturity. And what's interesting in the preeclamptic diabetic, because of the two competing diseases, diabetes creating macrosomia, IUGR creating a small baby, often you'll see a normally growing fetus, quote unquote, a normal sized fetus. But that doesn't mean that there's not things going on underlying the fetal condition.
Thank you so much, Dr. Dufour. We're honored to have you and sharing this information to our audience. I'm sure it's going to help quite a lot. Thank you again.
One last thing, I'd encourage you, go to the American Journal, download the paper, download the two videos. There's one on technique and one on a lecture for 15 minutes that I go over. It's a free download, so take advantage
Thank
of
you.
it. That's what it is. Okay.
Thank you.
Thank
Thank
you.
you
Bye.
so much. Our next speaker is my ex-mentor and one also of the very famous perinatal cardiologists in the US, Dr. James Huta. And Dr. Huta had a little problem with the presentation, so I'm going to run the and he's Dr. Huta, would you like to present yourself? Because I know that I know you've and I've learned quite a lot from you. And after me was the cardiovascular profile. Or now we've just heard about the mother's profile, cardiovascular profile score, and you're the one that looked after the fetus cardiovascular profile score. Can you tell us more about this, your journey with the heart and behind the cardiovascular profile score?
Yes. Well, thank you, Rima. Can you hear me all right?
Yes.
Okay, thank you very much. I just want to say thank you to Greg for a marvelous explanation of how hemodynamics in the mother can affect the child. And really, shouldn't we be taking care of both patients if we're going to do the right thing for fetuses with and without congenital heart disease? And we know that the two are very closely linked, as I'll mention in the talk. But the cardiovascular profile score came about because of the need before the onset of hydrops to identify the things that were causing the fetus to be sick. And what do we mean by sick? We mean a falling cardiac output at the tissue level. So in a decrease in tissue perfusion and the cardiac output in the fetal circulation for whatever cause is going to trigger certain signs and certain markers, just like it does in the neonate with heart failure. In the neonate, it's tachycardia, tachypnea, hepatomegaly, cardiomegaly, those four classic markers. In the fetus, though, it's going to be changes in the venous Doppler, in the cardiac size, changes in the umbilical artery Doppler, and changes in the cardiac appearance and function, such as tricuspid valve regurgitation. So if you take those five markers and you look at it with the potential to be normal, mildly abnormal, and severely abnormal, you have this kind of 5x3 matrix and a 10-point cardiovascular profile score, which has turned out to be very useful. For those of you who want to read more about the diseases in which the score can be used, there's a meta-analysis that came from the Japanese here about 4 or 5 years ago. And I think there's probably about 15 to 20 papers out about the cardiovascular profile score if you want to use it in certain diseases. And the prominent disease we're talking about today is placental-based IUGR. Now, it could be preeclampsia-based, it could be as you've heard, chronic hypertension-based, but growth restriction in the fetus is a major cause of perinatal morbidity and mortality, perhaps the largest as we approach the patient, particularly the patient with congenital heart disease. And I'll be talking today on a topic that I addressed at the World Congress in Washington back in August. If you're ready for me to go ahead, Rima.
Yeah, the Dr. Hitch is going to talk about a very interesting topic that he shared with all of us in the work, also with IGR, and from the perspective of a prenatal cardiologist. Okay.
So the two enemies of any fetus that has congenital heart disease. If we, oh, go back one, please. Go back two,
Sorry.
three, back one more. Thank you. The two enemies of a fetus with congenital heart disease is going to be the premature delivery, and growth restriction for whatever cause. And we're going to be focusing today on placental-based growth restriction. Now, you might say, well, gee, how should a cardiologist be looking at the cervical length? Well, guess what? Our perinatology colleagues measure this on every first trimester, second trimester fetus, and they know what it is. It's in their notes, but we pay no attention to it whatsoever. If you want to start looking at this, so you're going to then find out that it can be a predictor of preterm delivery. And there's nothing more fatal for a fetus with transposition or hypoplastic left heart syndrome than to be delivered prematurely. As many of you know, the mortality goes from 2 or 3% to 40 or 50%. By the way, the risk is twice for premature delivery and short cervix is twice for Black women and for women who have had more than 2 terminations. Now let's turn to the other major enemy of the fetus with congenital heart disease, and that is our topic today, intrauterine growth restriction. This is going to affect 20-some% of fetuses with congenital heart disease. The two diseases go hand in hand. 1 out of 5 of your babies with any congenital heart defect will also be predisposed on a molecular basis for placental-based IUGR, and that is defined by some as growth less than the 5th percentile for age. And so we're talking about a 3 to 4-fold increased risk of IUGR in this subgroup. Next slide, please. Now, it's with great humility that I show you a slide of a transvaginal scan. Oops.
Not work. Oh, okay.
Of a scan of a fetal cervix, of a maternal cervix. And this is from various papers, and it shows you on the left a long, normal, closed cervix, and on the right a cervix that's only closed for a short distance, with that black area in the middle being the uterine cavity, with only a very small area of closure of the cervix. And this is what it's going to look like when your patient is at risk of early delivery. You might say, well, otherwise we wouldn't do anything. But with a fetus who's at high risk of dying from prematurity, there may be indications for some management change by the perinatologist. Next slide, please. So just briefly, it's a placental-based IUGR we're talking about. The placenta is small. The uterine arteries supplying the placenta fail to grow properly in terms of their arterialization, and the mother has a condition called preeclampsia in some cases in which the placenta doesn't function well. And we've talked about the fact that there's thrombosis in the placenta due to thrombophilia present in the mother that results in areas of placenta that are being knocked out, if you will. Now, occasionally umbilical cord insertion abnormalities or fetal infection may be also altering the placental function, but I think we can basically conclude that up to 90% of the arterioles in a placenta are knocked out by the time the fetus is experiencing growth restriction. And by the way, he's also experiencing very severe hypoxemia at that point. Next slide, please. So the placenta provides nutrition, but also oxygen. And once we have this loss of arterioles, you see the thrombosis in the left-hand screen, complete thrombosis of the fetal artery. And in the right-hand screen, these white areas are all fibrotic replacement of the normal placenta by loss of the perfusion. And so this results in a PaO2 in the fetus, which is normally 25 or 26, of 10 to 15 torr, and sometimes less than 10. So single-digit PaO2s, if you can imagine that, are what the challenge is to the fetal circulation. Can you imagine a coronary artery experienced with that kind of PaO2 and the extraction that the myocardial cells are making on that kind of PO2? The coronary sinus PO2 must be zero. Next, please. So we'd like to be able to know which patients of ours are going to have this placental problem. And this is the point that Greg and I were just discussing, is that one can screen at 18 weeks or in that range, in that time frame, for uterine artery Doppler. And this is something that we would like all of our sonographers on the line and all of our perinatal cardiologists to learn how to do and to perform routinely, especially if you're seeing an 18-week fetal echo. The first trimester uterine artery is useful and has been shown in multiple studies. And the abnormal one in mothers achieves a sufficiently high performance to justify aspirin prophylaxis in those who test positive. And as Greg mentioned, the positive test is a notch in the in the uterine artery. Now, as he mentioned before, some people measure the pulsatility index and use that in an algorithm to decide who should be treated with aspirin. And we've talked about 2 baby aspirins a day for the mother as being the prescribed dose. And you might say, well, why aspirin? And the idea is to inhibit platelets and inhibit that thrombosis process that we just discussed. Next, please. Here's an example of a normal uterine artery Doppler on the left, and you see that there is a good diastolic flow. And on the right side, you see an abnormal notch that is indicative of an increased placental impedance. That's a reflected wave coming back from the high resistance uterine artery, and that's causing this notch. And this is the abnormal notches that are associated with the subgroup of people who may then develop IUGR. I was interested to hear Greg mention that on aspirin, some of these abnormal notches may resolve and become normal later in the 20-week, 30-week time frame. But that can be a part of our screening in this very sensitive group of ours with congenital heart disease. Next. So what does the IUGR diagnosis, how does it impact the fetus who is born with congenital heart disease? And this was a very nice study here back in 2015 that contrasted 41 IUGR fetuses who were matched with 82 controls, but they were matched for their congenital heart disease severity. And the mortality of the IUGR group was 15% versus 6% in the matched controls. The mean stay of those who were affected with placental disease was 56 days versus 28 days, twice the time in the hospital. And look at the hospital bill, nearly $500,000 for those who had IUGR versus those at $175,000. So now you can see that the push here would be terrific if we could prevent IUGR using aspirin, for example, or if we could begin to treat the mother's cardiovascular state in an accurate way to decrease her systemic resistance when it's high in particular, and in that case using nifedipine to actually optimize the perfusion of the uterus and therefore the oxygenation and the nutrition of the fetus. Next, please. This was just a study looking at singleton congenital heart disease fetuses, and they identified fetal heart failure, low birth weight in particular, and primiparous status as risk factors for those who needed cesarean section. And you might say, well, how do we know when there's fetal heart failure? And this is where the fetal cardiovascular profile score comes in. They used it in this study, and it was useful in predicting who would have an urgent cesarean section. Next, please. And so this is the score. On the left-hand side are the 5 categories: high drops, venous Doppler, heart function, cardiac size, and arterial Doppler. And you can see that on the left, this is kind of a 3x5 matrix with all the normals on the left-hand side. The -1 point would be irreversible ductus venosus, fluid collection, and Dr. DeVore has very intuitively recognized that a pleural effusion or a pericardial effusion can be a marker for the fetus with IUGR. And then, in fact, in studies, this has turned out to be true. So you'd get a point off for that. The venous Doppler, critical and most sensitive and most specific marker for the ductus venosus. Cardiac function, a tricuspid regurg may occur, especially when the IUGR, the changes in the placenta happen rapidly. When they happen slowly, then it's less common for the cardiac function to be obviously affected. And then finally, arterial Doppler with absent diastolic flow in the arterial Doppler, progressing to reversed diastolic flow. And so this is a study I'd like to highlight if those of you who are interested in screening for IUGR. This is a study done by Makikallio, Rossinen, where they looked at 75 neonates who were diagnosed with IUGR before delivery and followed carefully, and then all of them were delivered alive. And what they found was that there were 8 out of those 75 that died before discharge, including 2 who had severe cerebral palsy. And they looked at the adverse outcomes and tried to decide how you could predict what was going to happen. It turned out that the fetal cardiovascular profile score ranged between 2 and 6 in those who died or had CP, whereas it was between 5 to 10 with an average value or a mean value of median value of 9. So that looking at the cardiovascular profile score allowed them to predict when there was trouble, and it may have aided them in delivering those fetuses alive. Now, everybody in this group, if you will, was going to have some kind of abnormality. Many of them had brain sparing, for example, but that's not what predicts the outcome. It's the cardiovascular profile score that helped in predicting the outcome, including the heart rate variability and other measures. Next, please. So in addition, they were very smart because they wanted to say, well, is this really the heart that's causing the problem? So they measured enzymes in the after delivery from the cord blood that were produced by a fetal heart that was having trouble. For example, pro-ANP, NT-pro-ANP, NT-pro-BNP. These are hormones produced by an unhappy heart, and it turns out that those levels of those hormones, in fact, were elevated in those with a decreased score. The next slide, please. So here we see the plot of the score down below, where it's starting over on the right with a 10-point score and going down and getting a score that's 6, 5, or 4 was associated with a marked elevation of these abnormal cardiac hormones. Next, please. So I thought this was a nice kind of validation, if you will, of the score in this sense. So coming back to this maternal vascular malperfusion syndrome that Greg talked about, which can be associated with preeclampsia, IUGR, or many other causes, as we mentioned, we're going to have some progress in the future, probably with placental imaging, but uterine artery Doppler right now is the mainstay for early detection. In addition to the maternal cardiovascular the maternal cardiovascular profile that Greg so elegantly described. Next, please.
All right, that's the next one.
Yeah. Okay, and so something called the prostacyclin thromboxane ratio, and this is really has to do with clotting in the placenta, and it turns out that you can shift this ratio one way or the other. In particular, maternal smoking in pregnancy is associated with altered production in favor of vasoconstrictor, the so-called thromboxane predominance, and this can occur early in pregnancy and really lead to much more thrombosis in the placenta. Other things that the mother can be doing to cause thrombosis, including her intrinsic predisposition to it, or taking drugs, for example, that are vasoconstricting, could alter the placental function. Next, please. And so this is the ultrasound findings of advanced IUGR. Here we have an umbilical artery with reversed flow in diastole. So this would be a -2-point deduction on the 10-point score. Occasionally, you'll see that coronaries are lighting up, and this is because the coronaries are maximally vasodilated, trying to extract as much oxygen as possible, and you'll occasionally see those light up. This is a relatively nonspecific finding, but when you see it, you should pay attention. Much more relevant is the middle cerebral artery pulsatility index is going to be decreased with increased diastolic flow in the middle cerebral artery. And this is probably one of the best ways that you can screen in your patients who are having fetal echoes for an abnormality of placental function, in addition to the aortic isthmus that we'll mention next. Next, please. Now, here is an aortic isthmus Doppler that was mentioned by Greg, and we're sampling right in the aortic arch, distal to the left subclavian artery. And this aortic isthmus flow should be in systole go downward toward the placenta, and then it should go downward in diastole. But you see on this first waveform that actually there's reversed flow above the baseline, so that flow is draining back into the vasodilated brain during diastole in this disease. And this is true of these subsequent waveforms as well. This is a very serious finding because, but it's so nice because, as Greg pointed out, it's like a little impedance meter. You're sitting there with your meter in the aortic isthmus, and you're comparing the resistance in the brain to the resistance in the placenta. And this is the correlate, if you will, of the cerebral placental ratio that I'll mention next. Next, please. So this aortic isthmus flow is always net antegrade, but in fetuses with IUGR and deterioration of placental function leads to progressive reduction in the flow until it becomes mostly retrograde. This is a drastic reduction in oxygen delivery to the brain and a very good way of detecting this very compromised fetus. Now, we have to remember that some fetuses with congenital heart disease may manifest some diastolic flow because of decreased oxygen saturations in the aortic arch, but this is a dominant theme and a severe finding that will alert you to the imminent fetal acidosis and perhaps even fetal death and fetal distress. Next, please. Now, if you'll just click the arrow on the down below there, there's an arrow. Yeah, there's the aortic arch. And this is a video that you'll be able to watch if you, yeah, there we go. And now we see the aortic arch flow in blue in systole, and then following it, diastolic reversal. So the red flow in the distal aorta is reversed flow that is due to severe IUGR and brain sparing in the fetus, in this particular fetus, without any congenital heart disease. Next, please. So I'd like to then just describe a simple measurement that you can make to calculate a cerebral placental ratio. And this is the ratio of the middle cerebral artery pulsatility divided by the umbilical artery pulsatility. Many papers now are appearing about this ratio and are being used by perinatologists to help them decide about relative flows to the brain and to the placenta. And the normal value, or the cutoff that we use, is around 1.2, which it varies somewhat by gestational age, but we use this in the third trimester. In particular, we're interested in that pregestational diabetic patient where the growth may seem to be normal, as Greg mentioned, but in fact, they're severely growth restricted with severely low PO2s. And so sampling the middle cerebral artery in these is critical in the third trimester when you suspect that the fetal is not macrosomic, as he should be. When he looks normal in growth, you've got to be very concerned about severe IUGR and even impending death in the third trimester of these diabetic pregnancies and fetuses. Next, please. This is a paper or a slide from the paper of Hecker, which is dated now, but was very nice data showing how important the ductus venosus Doppler is in managing fetuses with IUGR. And here you see a reversal occurring, and that a reversal occurring 7 days prior to the onset of acidosis and fetal distress. And so I think we now have a time frame in which we can be monitoring the ductus venosus Doppler as well as the other findings. And if we want to try to improve the length of the pregnancy, Greg has just shown us how to do it. Adjust the mother's cardiovascular profile so that she's optimizing flow to her fetus. Next, please. And here is the cardiovascular fetal echo worksheet that we use at St. Joe's Hospital. But I wanted to direct your attention to the red squares. We're doing the fetal profile score that's shown in the box with the blue on the right-hand side there in every fetal echo. I'd like to suggest that in every fetal echo, you also measure the umbilical artery pulsatility index, that you measure the middle cerebral artery pulsatility index, the one down at the bottom there, and that then as you look at the ductus venosus, that's part of the score, but you're going to be looking then at a fetal cerebral placental ratio, that next to the last red box there, and that you calculate that on all of your fetal echoes. A simple addition which can add information about whether or not the fetus you're looking at already has manifested IUGR. I would also add that the uterine artery measurement is so simple and so easy to do that looking for notches and screening for notches in the uterine artery should be part of your routine early and later fetal echocardiography. I'd like to finish here because I think this is my concluding concept is that early notches are important. Umbilical artery with decreased diastolic flow, ductus venosus, a reversal. Look out, you've got about a week until badness happens. The middle cerebral artery with increased diastolic flow. The aortic isthmus, as Greg mentioned, you're going to be screening that hopefully on every patient with suspected IUGR, as well as doing the cerebral placental ratio and looking for cardiovascular profile scores decrease. Thank you.
Thank you so much, Dr. Huta. Beautiful wrap up, and also in continuity with what Dr. DeVore gave us. I'm not going to go away from the conclusion because this is a beautiful summary of looking at the IUGR from the cardiology point of view, because usually not all of us would look, I mean, I do, but I'm not sure every cardiologist or perinatologist would check the growth parameters in the referral. And also, we don't tend to get a lot of referrals for fetal echo for IUGR. Do you agree to that?
No, I think that's right. There are not too many referrals, but when we get one with or without the referral, specifically for IUGR, it's incumbent on us to look at the records that are sent. As I mentioned before, the records are going to tell you if there's cervical incompetence. They're also going to tell you what the head to body ratio is. And in IUGR, the head to body ratio is increased above normal. And so if you'll just look at those records, you'll know that they've already done growth measurement screening. They're going to give you the percentiles of the growth, and they're going to tell you whether the head is larger than the body. So you'll already have that information available to you so that you can match it up with the cardiovascular findings.
I'd like to, from the MFMs, to get referrals to cardiologists, to prenatal or fetal cardiologists, to really sort of do the Doppler as you're saying here. I mean, it's important to not just to look at the weight, but to look at the vascular system, the notching of the uterine artery, the score, the CPR, the CVP. These values are hemodynamics of the fetal heart that can help us also to plan the delivery and timing of delivery in conjunction with the MFM. I'm not sure if you agree to that or not.
Yes, I do. But I think you can see now that after Greg's lecture, that there is something you can do to optimize the mother's hemodynamics. And what better way to make the fetus get better perfusion and better nutrition than to optimize the mother's hemodynamics? You've already got the aspirin on board, but you're restricting her diet from things that could damage the fetus, but you're also adjusting her either with a drug that decreases the cardiac output, a beta blocker, or a drug that is going to lower the vascular resistance like nifedipine. Genius answer to the question I'm always asked: what can we do about IUGR?
Yeah, I think it's really not very much addressed. I remember Jack Reichert did a paper on the ratio of the cerebral placenta ratio, not just for they sort of measured the maternal status of depression or something like that. I'm not sure if you're aware of that, but it was also abnormal. So the cerebral placenta ratio is not just for the IGR. It could be used for other things, I think. I'm not sure if you agree, but this is what I've understood. Okay, we have two questions for you, Dr. Huta, or actually three. One is says that what about the modified thigh index in fetuses from diabetic mothers? Is it useful in delivery decision? So you just want to take the MPI rather than the whole score.
Oh, I see. Well, I think you can look, there's a reason that MPI is not in the score. And that's because when we looked at hundreds and hundreds of B fetuses that were prehydropic and were abnormal and such, it was only very, very late in the process that the MPIs went off. Now, in IUGR, they will go off as the fetus is dying, as the cardiac function is failing. The MPIs will become abnormal. But I think it didn't add to a score which was aimed at doing a pre-hydropic or pre-cardiac failure assessment to predict what was going to happen. But we do it routinely on right and left ventricles, and we keep an eye on it.
I also want to add, in medicine, having more than one parameter to take decision or follow a patient is much better than just doing one entity. So you could, I mean, this time person A did the measurement, next time person B did the measurement, so the percentage of error will be high if we're just depending on the tie or MPI. But with a score, I think the percentage of error will be less. And I think the value from my practice of the score is the language that you put on in the patient's file saying this visit it was 7, next visit it was 6. So this is an alert. So you're going to do something about it, or you're going to refer the patient for their MFM or referring obstetrician or whatever to take decisions. So I do believe that the score plays quite a good role in the follow-up of patients as well. I'm also very sort of happy that Dr. DeVore today, and of course you said that after him about the aortic isthmus and the IUGR and the reversal. Remember before he left, Dr. Huta, he was saying that this is it tells us a lot about the cardiac function. Just this measurement, the diastolic reversal in the descending aorta at the isthmus, tell us a lot about cardiac function. Could you please sort of elaborate on that?
Well, it tells you about the relative resistance in the brain and the placenta and how advanced the increase in placental resistance is in the fetus. Now, this is just fetus we're talking about.
Yes.
Right? Yeah. So it's just it stands in for the CPR. And it reflects the relative instantaneous resistance from the brain to the placenta and how severely affected the placenta is and how severely vasodilated the brain is.
So it's sort of highlighting placenta-brain relationship in this flow. Okay, one more question as well. I hope so. It's a question. Well, it says thanks. Just thank you. Okay, I'm so happy you had the time to come and talk to us. And I would advise all of us. I think the take-home message is to do the uterine placenta ratio, and not to forget the notches. However, Dr. Huta, I think early in the first semester, the notches are not that important. The first semester, the uterine artery notch.
Oh, yeah, they are important. By 18 weeks, you can predict.
No, first trimester.
Well, okay, fine. I don't know about first trimester. Most of us
Could be part of normal.
Yeah, but by 18 weeks, that's when you would decide about the aspirin therapy.
And the important thing that not a lot of people do regarding the cerebral-placenta ratio in pre-gestational diabetics. That's beautiful. So we have to do it, because when a diabetic comes, usually they're difficult to scan, at least in my practice. They're always overweight and not easy, and get a lot of information about, you can easily say that if there's any congenital heart anomaly or not, thickening of the walls, blah, blah, blah. But this is very important that if you see a good sized baby with an abnormal hemoglobin A1C, you have to do the cerebral-placenta ratio. Is this correct?
That makes good sense to me. But let me hasten to say that any perinatologists listening, we are not telling you when to deliver babies. We're giving you information. We're giving you information to make that decision. Thanks.
We always share the patients. We always share the patient. Thank you so much. And I'd like to thank all our audience, and I'd like to thank them for staying late and also for sharing the questions. Just want to say that if you're interested, you can find the whole fetal series under the fetal series. With the fetal series, you can find all our 27 webinars there. And we're very happy to get any feedbacks from you. Our next meeting is going to be with Dr. Silverman. It's going to be in December, and just before Christmas and the New Year. So thank you so much for coming, and please spread the news and share the link of this important webinar with your friends. Thank you, and goodbye.